Good afternoon and welcome to the Arrowhead webinar series. Today's presentation is called Making the Transition to Digital Dentures Practical, Efficient, and Profitable. We are delighted to welcome Dr. Frank Lasello, who is Director of Removable Education for Ivoclar Vivident. We appreciate him taking time out of his day to share his considerable expertise on this important topic. We also want to thank everyone attending today's webinar, and we hope you find the information presented today helpful in making your practices more productive and increasing the efficacy of the treatment you extend to your patients. Before we begin the presentation, we have a few items to cover. First, all attendee lines are muted during the presentation. We will have a Q&A session during the last 10 minutes. You can submit your questions at any time by typing them into the chat/question window visible on your screen. Second item is at the end of the webinar, a short survey will appear as you exit. Please take a moment to complete it, as your feedback is considered very heavily as we plan future webinars. Also, if you have your AGD number, you can enter it into the survey and we will file the CE credits for you on your behalf. And lastly, we'll be posting a recording of this webinar online shortly after the presentation today. Be sure to like us on Facebook or follow us on Instagram to be notified when that link is available. With that, it's my pleasure to turn the time over to Dr. Lasello. And to begin the presentation, we're going to post a quick survey or a quick poll asking how many of you who are in attendance are actually doing webinars right now. So go ahead and answer that question. It's a one-question poll. We'll give you about 30 seconds to do that. So Dr. Lasello, go ahead and start talking, and I will let you know the results as soon as they're in.
Oh, that's great. Well, thank you, Matt, for the introduction, and certainly thank you everyone who is in attendance, because everyone's taken their time, valuable time, and to share with us today, and what I think is an extraordinarily exciting topic. And I'll get into a lot of the details. I asked Matt initially to do the survey just to get a general idea on everyone's experience, if they have any experience or multiple experience doing digital dentures, just to be interesting to kind of reflect back on those numbers maybe at the end of the program. I thought first I should give you an idea who is lecturing to you and from what uh, uh, life experiences I've had. I went to the University of Buffalo for my undergraduate, went to Los Angeles VA Medical Center, and for my residency and general practice residency, back to Buffalo for prosthodontic residency, and I stayed in Buffalo for the rest of my career, basically. And I was chief of the dental service over at the Buffalo VA Medical Center, and director of the prosthodontic residency program for about 22 years. So I share an academic position at the University of Buffalo. So I have certainly a academic background that I'll probably express in some of my academia ideas. But also, I joined the Ivoclar as a consultant, the director of the Sarasota Education Center about 25 years ago, and have had so much fun with the company because it gives me the opportunity to be on the cutting edge of a lot of dreams that I always had on things that could be better in removable prosthodontics in particular. Currently, a director of the research and education and product development with Ivoclar Vivid, and again, is a very, very exciting position to be in. However, all these different titles and things, I actually just like to be a teacher. I really do. I like sharing information. I get so excited about something that works for me or something that's that's newly found out or newly practiced and getting great results. And I just love to share it. Pretty much like all of you, we're all in this together, and we're here for a common purpose to provide better patient care. And I will say, making this transition to digital dentures, unquestionably, you will provide patients a better experience and better care in the process. So So for that, it really does fulfill its purposes. So let's kind of get a little bit where I understand how difficult it is to make a transition. I assure you that I am a dinosaur prosthodontist, trained in the very traditional methods of removable prosthodontics. Howard Payne was my mentor, and certainly we did things very, very traditional for many years. So making a transition towards digital I thought would be a challenge, and it is a challenge in many regards. But it's certainly it's confusing because you hear a lot of information, and I think there's a certain hesitancy to learn new things or to make changes in your everyday practice. That's not an easy thing to do, and it's easy to put off and put off and put off because you just don't want to face the new challenges. I am going to show you different workflow options and going to kind of summarize a couple of them that I think are very hand selected here to give you the opportunity to make this transition as simple as possible and to do as minimal changes to your effective virtually no changes to your clinical techniques, material choice, and et cetera. So we'll kind of hit on that. Now we have a short time, so this lecture really is a flyover, and I'm going to cover a lot of topics, and I'm going to talk a little bit on the fast side, just so you kind of get through things. But we're going to talk about uh, a lot of information here, just kind of the outline that we're going to kind of flip on through. So very briefly, I'd like to start with discussing a little bit about a digital concept, and we're talking about getting data acquisition from the patient. In other words, we have to scan um, the patient's tissues or impressions made by the patient or their existing dentures, whatever it is in the different workflows. But we have to do a scanning process to start the data acquisition. This data then is transferred into a software module where we could do our computer assisted design, so our CAD part of the process. And then from here, after we finish our design, then it goes into a manufacturing, whether it's printed or milled manufacturing is the two most common methods to make the final product. So, what are the different manufacturing options? And again, I didn't want to get too technical, but on a personal note, I've been with the inception of the digital process right from 2015 when we started this with uh, over coffee, drawing designs on papers and stuff like that to really come to where we are today. So it's really been a kind of a wild ride and very enjoyable, I might add. But there are basically with our Ivotion system, there are four different uh, manufacturing options. We'll kind of touch on these briefly, and they're kind of in a chronological order. They're all currently available, but they're kind of a chronological progression. So we'll just kind of flip through it quickly. One is the what we refer to as the artificial tooth process, and this is where the digital world and removable it basically started, where we would mill out the denture base, and then we would tack on or bond the carded denture teeth to the base. So typically this was the origin that all companies were kind of starting from. So a milled base with the slots for the teeth, and then they individually hand bond the individual teeth. And as you could, the idea here is that there's a lot of finishing involved and a lot of individual attention. It was exciting when this process started that we were able to do this, but the process of finishing was still a little extensive and made it not to be the most practical process at this particular time. But it is a way of getting carded denture teeth uh, to a milled base and using the software design technology. The what's referred to as the oversized process, and this is probably our uh, I'm not sure which one is used more often, this one or the monolithic, but it's certainly a one of our touted processes. And I'll try to explain it. Again, this starts with a disc for the denture base, and it does have a couple of options for a different disc for the teeth. The Ivotion Dent Multi is a polychromatic disc, so it's a little more aesthetic and the manufacturing of the teeth compared to the Ivotion Dent. Both are very nice, but these are milled. But they're milled only to 80% of their final mill. So that's kind of where the oversize name came from. So they're not completely milled. They're about 80%. So they're basically for the teeth and for the tissue, they're oversized. And this gives the opportunity to bond the denture teeth to the base at this particular time where they're not finished. And this is the beauty of this process is now it goes back into the mill, very, very precision methodology and a patented methodology here as well to go back into the final mill. It has to be a special mill to then finish the processing of the next 20% of the processing. Now, what this does, it finishes the denture virtually almost 95% finished. And the interface between the teeth and the tissue is controlled, so it's minimized and it's clean as a whistle, and totally indetectable by this particular process. So it's a beautiful, clean process to carry through the bonding process because it's a two-piece denture that probably exists. This is probably the um, just the number one technology for this process. Now, interestingly enough, we have a monolithic process, and this I wish I could spend an hour to explain because this is absolute genius. I know the creators, and they're absolute geniuses. And it's a way of putting the pink and the white together in one disc, which we kind of joked about, and here it became reality. And this particular disc is put into the mill, and it's a final mill. And the teeth and the gingiva are milled as a unit. And hard to believe, but they're indetectable. And it's as I said, a genius process in geometry that allows this to occur. But the beauty of having a monolithic is not only just the simplicity of one disk, it's the chemistry, the physical properties. Again, this is a very carefully patented process in how to fabricate these discs because they're not processed separately and glued together. They're processed together so that the chemical properties, there's no interface between the pink and white. It's a monoblock of material. And therefore, we know acrylic is very strong when it's in its bulk form. So the strength of the monolithic dentures are probably are testing at least 3 times the strength of a non-monolithic denture. So pretty impressive statistics with this particular methodology. And then lastly, and newest to the game, just very new, is a print-based mill teeth. Now this is a process where we have a new Ivotion print material, which I'll talk a little bit about its properties very briefly, but it's a method to have a print base, then have milled teeth bonded to the base. And we've gone in this direction because the milled teeth are by far the more aesthetic than printed teeth at this time. And the denture base, we took years to develop this, and our goal was to have this as close to the traditional polymethylmethacrylate, the PMMA denture acrylics as possible. And we have succeeded. This particular print base, it feels like, it grinds like, it looks like, it repairs like, it relines. It polishes like our traditional materials. So it really is quite an advancement into the print technology with this iVotion print material. It doesn't have some of the advantages of the milled in a sense that it's still a two-piece and requires bonding and does require technical expertise to put them together, but it doesn't have a final milling process to clean everything up very easily on a technical basis. So it does require some extra laboratory time. But this exists, and it is a interesting print option that we have at this time. Okay, what's the elephant in the room? Do I do it a mill denture? Do I print denture? A lot of controversy in the literature and a lot of things to look at. This is kind of personal. I did a nice literature review, some of the latest articles to some very credible authors to look at the differences currently, and to look at the print versus the milled. And there's advantages to the mill. There's some disadvantages to mill. There's some advantages to the print. There's some disadvantages to the print. And it kind of boils down into that on the milled denture today, and I'm speaking just literally today, the materials are time tested. And so we've had our PMMA materials because the milled materials are exactly the same chemistry as our traditional denture teeth and base materials. So they've been pretty much time tested. The physical properties, generally speaking, are far better for the milled denture processing, and aesthetics. Milled certainly still has the upper hand on the denture tooth aesthetics in particular. The print, why well, uh, print, requires or doesn't require expensive apparatus to have them manufactured. So that could be a factor in certain laboratories that don't have the equipment for it. You could do multi-production, making it excuse me, a little more efficient in a laboratory, but it's not limited, and it's not limited to a size of a disc. In others, you got a extra sized, huge denture or an obturator or something of that nature. You may not be able to do it with a milled process. You may have to do a print just because of the odd shape that it might entail. But generally speaking, today, I think if I was a technician and I would probably choose to do a oversized or a monolithic milled product because my gosh, there's no cleanup. It's the cleanest process to make a denture that exists. If I was a clinician, I like the idea of the time-tested materials. I'm just a little bit more comfortable, and I like the aesthetics. And again, if there is a significant price difference, then I could consider a printed denture, especially with the new innovations like we just showed. That might be a possibility, but it probably is really related to cost and not the quality. I think I speak honestly on that, and to kind of leave you with that particular message. But tomorrow might be different. But today this is the state of the art. The technical and clinical advantages, real briefly. The the milled materials are they're pre-processed, so there's very little that could change in the laboratory regarding their technical performance. So having them pre-processed, industrially processed, there's no very little room for error. So the properties and the performance is going to be very predictable. For the laboratory technician, they love it because the teeth are their starting point is having a whole arch of teeth preset, and the gingival architecture, the same thing, is preset. You can be tweaked and it'll change here and there, but by gosh, you're off to the races. Physical properties, as I mentioned, the accuracy of the milled process and the print process, by the way, is extremely accurate. Off the charts, better accuracy than traditional processing. Absolutely off the charts. Strength, we kind of touched on that, especially with the monolithic. significant strength differences could be displayed. And kind of a side benefit is the fact that when you manufacture, whether it's printed or milled, the denture base is uniform thickness, which is a technical result, but it has clinical advantages because patients love the feel of these dentures. And I think most of that is due to the fact that it has a uniformity of thickness, which gives them a feel that the dentures get lost in their mouth. I've had comments from patients concerning the milled dentures, the digital dentures that I never had with the analog dentures, how they disappear in their mouth, and just kind of, and obviously with the accuracy, the fit is, you know, much improved. So a lot of things there to tout as advantages. On the clinical side, as a clinician, and you could either be involved in the design process or you could communicate very effectively with the laboratory. And you could communicate with, cast correction to start with. When we take impressions, there's always bubbles and blips and little voids or whatever. These can be all corrected beautifully, and one correction might mean one less sore spot. So this technology is terrific for correcting the cast. You could dictate very graphically where to put your peripheral borders. If it's an impression tray, you're going to design it one way. If it's a final denture, you design it differently. But you could very much discuss with the laboratory how you want your peripheral borders designed. And because of the graphics of this technology allows you to do that and make that level of communication with the laboratory. Again, with relief, whether it's a custom tray or it's going to be a final denture, you could discuss with the laboratory different methods of blockout and relief. And these end up, the payback for these are minimal, if any adjustment at the time of insertion or at the time of doing impressions. So these are terrific technologies to help you as a clinician, your clinical procedures. And lastly, on this page here, we've got equilibration. I was skeptical of being able to equilibrate the teeth. The equilibration process in the digital arena is extraordinarily accurate, and it does provide a better occlusion of the day of insertion. And I'll show you an example of that when we get to the insertion stage. Certainly a more stable base. We'll touch on that a little bit. Your chances of getting a accurate jaw registration is vastly improved because you're dealing with a more stable base. Your post-ams, I don't do post-ams. You don't have to do a post-am because of the tremendous accuracy of the method of processing. Or if you do a post-am, you could discuss this with the laboratory, and they could do a digital post-am as possible. But there's some options here which we certainly don't have with the analog. And the reason you have options because there's no processing error. And of course, the electronic memory, and this is huge. Very important to the patient that and once they understand this, they'll express to you how meaningful this is, where their design is electronically captured, and we could come back at another time and have a denture remade very easily. Whether it's an extra denture, or if they lost a denture, broke a denture, the thought that you could remake the denture exactly the way it was for the first time is very comforting to the patient. Plus, another thing we got to just talking bad about it before we got on air, we're seeing patients more comfortable in having a new denture made in a shorter period of time, just to kind of refresh their dentures because the process is so much simpler for the rebate because it's already been done. And so you may see patients refreshing their dentures instead of keeping that 20-year-old denture. They may want to exchange that in a much shorter period of time to get a cleaner denture base and things like that. So interesting options are open here. Bottom line is communication and between the clinician and the technologists in the dental laboratory. The graphics of this technology truly get you away from writing that prescription, you know, make a denture. Now you could really get in conversation with the laboratory and discuss the all the things that we had talked about, and then so it's just a monumental dimensional change in your quality of communication, and obviously, bottom line is better patient satisfaction. So let's get into it. Let's talk about our options to scan. Well, we talk about laboratory scanners or intraoral scanners, which could be also used not only to capture tissues intraorally, but it could certainly be used as a scanner. And you could use it to scan impressions or dentures as well. So, depending on the logistics of your personal logistics, your access to a lab scanner, your access to an iOS scanner, you can make personal choices on how to get your data acquisition depending on the particular workflow that you're selecting. And there's a variety of workflows. And I'm going to very briefly kind of touch on this, but this is some of the things you can do with either scanner, basically. And one is to consider copying the denture. You may have heard this terminology before. This is where you could do a lab scan or iOS scan, chairside, and you could scan a patient's existing dentures and have them duplicated. So you can make a duplicate denture or a copy denture. And why is that exciting? Well, because then you could use that duplicate, you could print it relatively inexpensively, and then use that for your impression trays to take an impression and bite in a duplicate of the patient's existing denture. It was a technique that caught on, very, very popular, and it has been replaced, which I'll talk about later in the workflows, but at least initially it was a great idea. Now, you could take impressions and a bite in the patient's existing dentures or a replica of their existing dentures, like a copy denture. And that's certainly a technique. And again, those could be scanned chairside, or they could be scanned in a laboratory scanner. And that could be your entry point into the digital technology. If you don't have dentures to start with, or you choose not to use the dentures, we could start from scratch, which takes some preliminary impressions, but here we have to get a bite record, and this is like I'm showing here is a center tray record. You may or may not be familiar with it, but basically it's a mush bite. So in order to get into the software technology part of it, you could take individual impressions, that's fine, but in order to get them to be related to one another, you will need to get a bite, an external bite, like I said, like this mush bite. But that's a possibility to get you as your starting point. Now, the wax rim bite, I call this a positive scan because this is where the impressions are now poured. So now you have a positive model. And yes, you can use this as your entry point. If this is the most comfortable position you're in today, then fine. You could do a wax rim bite, just don't you're not changing anything that you do clinically. And then this part could be scanned. So the individual models are scanned, and then the wax bite is scanned, and that now enters the design module for the new dentures. The iOS tissue scan, again, is a positive scan because now you're not scanning impressions, you're scanning the actual tissues. And this I'm not going to get into a lot of discussion because this is a seminar easily all by itself. But it's just to show you the the, um, all the different workflows and different scanning options. It is just that it's another scan option. So it doesn't mandate that you, for doing digital dentures, you're not mandated to do tissue scans intraorally. It is just another option. So, and that has, as I said, that's a lecture in itself to get into all the particular details. But this, I just wanted to give you this flyover view of all the different scanning options to show you that how it's varied, and it might Some will fit better than others for your particular situation. So let's look at the actual clinical workflows. And if you did a survey on the patients who are presenting to your office, you'll probably see that the vast majority are probably coming in with a replacement denture, and probably a lesser majority would be coming in for immediate dentures. And then down here, probably very few patients actually come in who don't have a replacement or don't have a need for immediate dentures. So if you look at those statistics, well, let's cherry pick. Let's look at the replacement dentures as being a workflow option that I think you want to consider. Now, all of these could be transformed into a implant supported restoration of various types. So these are the clinical workflows that you're typically introduced to with a patient coming into the office. So let's take a look at our replacement dentures. And you could have a patient walk in with their current dentures, and yes, you could take impressions inside their current dentures and a bite registration and scan that, and then send that to the laboratory. Or you can make a copy of their dentures and then take impressions, a bite in the copy denture, and then send that in. Lastly, I'm gonna come back to this. This is a try-in tray denture, which again takes advantage of the patient's existing dentures, but it's scanned differently. It's scanned like like you took impressions, which you haven't yet, but it brings the dentures into a design module. So just kind of hang on that for a moment. Um, let's look at immediate dentures. Well, we have two ways to look at the immediate denture as far as starting that. We could take traditional impressions, change nothing. Take impressions and a bite registration, send that to the laboratory, and they could scan that. Or you could do an intraoral scan. I will say this, if you are of the inkling to want to take intraoral scanning, this is where you start. Immediate dentures is a very easy intraoral scan because the existing teeth act as markers and allows you to do a very much easier scan than trying to scan a patient with smooth oral tissues, which could be a little challenge. So it's a good starting point if you want to choose to do an iOS scan. But again, either way, we're going to come back to immediate dentures very briefly in a minute as well. Now, if you have no replacements, yes, you can do several different things. One is to do this. You do our traditional wax room, as we mentioned. Or we have a workflow option here. We call it the directed try-in technique, where you take individual impressions, do a center tray record, and optional, you could do this called the UTS CAD, which gives a little bit more information to the laboratory concerning the occlusal plane. And that's an option starting from scratch. And we also have what's referred to as the biofunctional prosthetic system, the BPS system. This is this creates specialized rims that has Gothic arch intraoral tracing devices attached to it. Rather sophisticated technique, and I wouldn't recommend it as a starting point. It's kind of more of an academically interesting device, but it's incredibly accurate with the Gothic arch tracing concept. So if that is of any academic interest to you, this is the best I've ever seen. But that's another option. Then coming to the implant options, obviously that could apply to any of these. And if it's just a locator attachments where you just have a traditional overdenture, that's fine. You just uh, everything is kind of the same except you make room for the overdenture implants. If you have a fixed bar supported, there's a way to do a sleeve denture that can be bonded to the bar. But that's gotten some attention. But what's gotten a lot of attention is a fixed option, a fixed detachable option. And this is kind of based upon the fact that the monolithic denture option that we have is so strong that you could consider, excuse me, that you could consider using it as a long-term temporary or a final implant supported restoration without bar support. So this is gaining a lot of traction. It's not our recommendation, but it is usually being utilized by a lot of laboratories as I said, considered as a long-term temporary or an inexpensive replacement that is periodically maybe has to be redone because it's going to get beat up a little bit more than a zirconia type restoration. But it's gotten a lot of traction, kind of interesting. So let's talk about a couple of transitional workflows. And the one I'm going to recommend the most is because I do it the most. Patients walk in my office, traditionally with an existing denture. So why not take advantage of that? So what do we do? The patient walks in with an existing denture. So let's walk through it. Um, Existing denture, we put it into the patient's mouth and we evaluate their existing denture. You look at the midline, look at the incisal length of the teeth, you look at the mandibular incisal length, you look at the support, your occlusal plane, in this case, the teeth are hanging posteriorly, or the incisal length is pretty good, maybe a millimeter longer, but you do all your evaluation and you document their existing denture. And this is like a try-in, and that's exactly what you're doing. You're trying in their existing denture and you're talking to your patient. What do you like? What don't you like? And this patient, I think, was very adamant about, I like my teeth. I like to look very similar to what I look here. I might want them a little bit longer so I don't get the gummy smile, but but listen to the patient and write it down. It's an incredible transfer of information. I do a bite registration because when these are scanned, you have to kind of hold them while they're being scanned. So I think by doing a bite registration, it's a little easier to do the scan, which I'll show in a minute. But it's optional; you don't have to. But I traditionally take a quick bite, and then you do a laboratory scan or a tissue scan, IOS scan. So this is me scanning the upper denture, and what I scanned was the tissue surface of the denture, and then I scanned the oops, then I so I scanned the tissue surface, but I didn't scan the palate. Now, if this was going to be a copy denture, I'd have to scan the entire denture, and I can't leave any gaps. So doing a copy denture scan is by far more challenging than what I just did here. It's a very easy iOS scan or easy laboratory scan. So it looks like this. Here's our bike registration. Just change the color a little bit so you can see it a little bit better. So we got again, these are a patient's existing denture. And I didn't bother to get the palate, and I don't bother to get the lingual of the lower teeth. So easy scans of the upper and lower dentures, and then the bite relationship. Now, why is that so special? Because we could take the patient's existing dentures, we could scan them, and now it goes into the computer, the software, in the design module. If this was done as a copy denture, I can't do anything to it other than replicate the denture. But by going into a design module, like I can here with this type of scan, now I could actually design a new denture and I could make custom changes to my denture base so I can make custom impression trays. So it gets up on the screen. I could add, if this was going to be, and it's going to be for impressions the next appointment, I could ask the laboratory, yes, block out undercuts, add relief, and you could discuss where you would like relief, just like you're doing your traditional analog custom impression tray. Whatever your philosophy is, you could now communicate this to the laboratory. You could communicate how you like your border outline to be, or you could participate with a team view technique that could be offered to you from the laboratory. So you could actually work with the laboratory and decide where to do your outline. Why is this so nice? Because I don't want to pick up a burr chairside, and I don't. I routinely don't have to pick up a burr to grind and open up my flanges or take the denture border down. And so what you're doing here is predetermining your outline, in this case, for a custom impression tray. Now, also, we could ghost in the patient's existing denture, right? So that could help me, based upon my evaluation of that denture, where I want to put my teeth or my occlusal plane at this point. Because that occlusal plane is now going to dictate where the next button you press on the computer will put the teeth according to that occlusal plane. So how exciting is that? We're still not even treating my patient, and I'm already selecting teeth, setting teeth, and this is your first guesstimate on where to put the teeth. And then typically these are printed as a custom tray and a try-in. So they're try-in trays is where the terminology came. Because what the anticipation is the next appointment, which I consider basically the first treatment appointment, I have custom trays. I take my final impressions. I put this in a patient's mouth, and I'm looking at my new denture design. So I'm looking at the teeth that I selected, where I put the teeth. I've got my first preview of my selection process and my placement process. Then I could look at the good, bad, and ugly and make my documentations, what I want changed or what I don't want changed. And then this goes, and I do a bite registration, and this goes back to the laboratory to be rescanned. Okay, so we rescan the impressions and rescan the bite. Could be done with laboratory scanner, or it could be done chairside with a chairside scanner. And again, we look at the new design and how that's going to affect, depending on the changes you want to make. And then we could go ahead and make a prototype denture. And I will add that if you have a high degree of confidence on the information that was provided and your try-in went extremely well, you could actually go to a final denture. I mean, literally, your next appointment could be a final denture. Crazy. And so it's a real could potentially be a time saver, or at least it's the steering apparatus of this particular technique um, is it gets you to your final point much easier, much better, less guesswork, much more efficiency into the process, less chair time, less everything on the clinical side. So what's the advantages? Well, you got the existing denture still as your reference matrix in your tooth selection and the position of the teeth. And the scan is an easy scan. It's not a copy denture scan. It's an easy scan. And then you can still make changes because you're in a design module. And so you have certainly with the potential fewer changes. Disadvantage, I don't have any disadvantages. And that's a God. This is my go-to technique. Any patient walks in my office, has existing dentures. There's no reason to do it any other way. So that's certainly a technique that I would recommend as your one of your transition techniques. Let's say you want to stay familiar. Okay, stay familiar. Do your traditional wax bite registration. So now you have your upper model, lower model, your wax bite, and this could be scanned. And I recommend using a laboratory scanner. So I don't want to do this with an iOS scanner. There's no advantage. Send it to the laboratory, and then they would scan your models and your wax rim bite registration. And then this goes up into your design software and it's virtually mounted. So now you start here, and again, your virtual mounting is going to allow you to select an occlusal plane using your wax rim as a reference matrix where to place the midline, the incisal length, the occlusal plane as your starting point. That's transferred just by removing the matrix, and now you set the teeth accordingly. The computer gives you a initial proposal based on the occlusal plane that was selected based on your wax rim, and then again we go to a prototype denture. Now I use the word prototype because this is a prototype of the denture. It's not a try-in denture. It's not a sloppy try-in denture. It's a prototype, an exact replica of what could be the final denture. So advantages, what's familiar. And if that gets you into the game, by all means, this is a great transition. This is where most of our universities are transitioning with this particular technique. Disadvantage, I guess, is that you're not using all the whistles and bells of the digital technology, like we kind of described before. But that's okay. That's okay. If this is a good transition for you, then it's an excellent way to go. Immediate dentures, whether you do it, with the traditional impressions or you do an iOS scan, I think is a very good opportunity uh, to deliver better patient care because this technology is amazing and how it replicates and locks in what the patient's existing condition was, and you could now reference it by looking at the patient, making decisions, documenting them, and then your final um, immediate denture is going to be based upon a very careful analysis of what the patient's existing teeth were and what their desires are. Now, if you do it with intraoral scanning, same thing. This is a great opportunity to get started with intraoral scanning if that is your goal, which would be mine, to be quite honest with you. And then the same process once you get it into the design. So immediate dentures is a opportunity to do better dentistry for your patient using this technology, hands down. So it's a good transition. Maybe not your first denture that you want to do this way, but certainly it should be on your list of easy transitions. Very briefly, selecting teeth. Just going to show you our traditional ways of selecting teeth. This built into our system of iVotion, we've got 4 different molds of teeth that are brought into the system. But instead of looking at a two-dimensional card of teeth, now we could look at setups. It's a total different way to look at denture teeth. So I'm going to kind of flip through this. We're looking at different molds of teeth that are all preset. So you could become a student of aesthetics of these different molds by carefully being able to study them in a much more graphic manner. Now, patients, generally speaking, don't want major changes who have existing dentures in particular. And so they may say, maybe I want it just a little bit longer, maybe just a little bit this, but don't make me look totally different. So one thing you could do is you could select teeth like I did here. So I select the mold of teeth, and then I could grab it. You just pull it down. Well, I like to do about 3/4 of the way down, and I could make a direct comparison to the patient's existing teeth, and I could change molds and look at the characteristics of their existing teeth to try to get a general idea of size and et cetera to kind of like this is obviously much larger than their other teeth, but I could flip through just by hitting a button or the laboratory can and get a much better approximation to their existing teeth or their desires that they want to make in their changes. And then I just flip that back up into the positions. Posterior occlusion, got 2 different occlusal schemes. There's a semi-anatomic occlusion, which is a little bit more articulated like natural dentition. So it's a little bit tighter of an occlusion on the posterior, but pretty, very attractive posterior occlusion. And if you go through excursions, which we can do in this technique and do our markings, you will find that the semi-anatomic a little more complex in the teeth that are making contact. It's a little bit challenging to interpret them, but you can see the degree of accuracy is phenomenal with this technology. Lingualized occlusion may be your favorite. There's a little difference in this technique. Again, the palatal cusp is making contact, where the buccal cusps on the maxillary arch are out of contact. So it's different than a semi-anatomic. We go through an excursion. We can look at the contacts quite a bit different. They're lingualized occlusion, meaning that only the maxillary palatal cusps are making contact. So it's a little bit easier to understand, a little easier to adjust clinically if necessary. and there may be a preference for you to do that. So let's go to the clinical try-in, which is really going to be, on all of these, they all lead basically to a try-in. So regardless of your different workflows or what you scanned or whatever else, it's going to eventually get to a try-in, or what I like to call is a prototype denture. And so your difference here is, this is where the difference is. You're maybe used to the traditional wax rim try-in. Now you're going to look at a resin try-in, but we're going to call it a resin prototype, because the prototype means that this truly does fit like the final denture. It's exactly the same as the final denture. No relief, no nothing in this denture. So when you do your assessment of fit, um, with a traditional case, you're blocking out the cast, you're using unstable base materials to make the bases, and so it never fits like the final denture. Where digital, it does. It's perfect if it's exactly the same. Kind of looking at a try-in.
I need to count from 1 to 10 for me. 1, 2, 3, 4.
And I think you all know what that looks like. You're trying to do a try-in, and the denture is flopping all over because it's not a prototype of the final denture. Where you're working with this digital technology, you're working with a complete different animal. So you try these in. If they fit, they fit. You know with confidence the final denture will fit exactly the same. If they don't fit, then you better take an impression. So there's no ands, if, buts, or guesswork with the fit. Tooth position, again, you could document if you want changes. I want to change the midline, I want to change the size length, or whatever it might be. You could document the changes, or you could mark them and tell the laboratory, shorten the teeth to where I marked it. Or you could grind them. You could do anything you want as a means of communicating to the laboratory. Occlusion, going to show a quick video. This is how I routinely, like in this patient, occlusion's off, right? So let's correct the occlusion by taking a new bite, and I grind off the lower posterior teeth very, very easily, making room for bite registration material, get away from any interferences on those posterior teeth, put some bite registration material. I'm dealing now with very, very stable bases, and I'm going to get myself a accurate bite registration for sure. That's a great technique. Little side benefit here, patient approval. They could take these home. You have a discriminating patient who wants to look at it a little bit more carefully, give it to them. They could take it home. No fear of teeth falling off. So let's go to our insertion. One of my mentors, James Cradiville, terrific individual many years ago, but he had made that comment about the insertion appointment is the process of eliminating errors. In other words, it's the accumulation of all the errors that you've made in the process is going to come out and bite you at insertion. My technique or my philosophy is, let's eliminate those. So my day of insertion, I don't have errors. And by doing the cast corrections, the border outlines, the relief, the blockouts, the equilibration, my insertions are routinely that I don't pick up a handpiece. I don't have to grind anything day of insertion because I've pre-studied the case, pre-designed it to minimize. My goal is zero adjustment, and I'm at least 90% there. Can you make gorgeous dentures? Yes, you can. Can you make very aesthetic, satisfying dentures? Yes, you can. Could you do tissue staining or add-on? You could do a lot of things with this. And this is what's most exciting. This is an insertion of a patient, like minutes before, just minutes before this video was taken.
Close.
I inserted this denture. Look at this.
Close. Tap, tap, tap.
I have never inserted an analog denture
side to side
with that degree of accuracy. So this is to me the bottom line of the technology, that you're able to deliver such a quality experience for the patient. And again, the the retention. This is a patient we did no post-am. I
Just
think it's going to
relax.
show it in a minute.
Retention of the lower denture is very good.
And typically the maxillary retention, you could pick the patient up off the chair and throw them
Retention
across
of
the
the upper
room.
denture.
Typically, it's quite exceptional retention of the maxillary arch. So anyway, to end us, communication is the key to success. Working with the laboratory, they could be a tremendous guide as you start the transition. Start the workflows, cherry pick the workflows that are easiest to work with, and I think you'll find. Lastly, I'm in Buffalo, New York right now, anticipating the weather that's my house that sometimes I can't find in our beautiful winters we have here in Buffalo. But on the other hand, my wife and I are ready to get out of here and go south, and we have a place in Florida as well. So we're kind of looking forward to that. But thanks for your attention. Thank you very much for attending. And if there's questions, we have a few minutes left here for a question and answer. I'm a little bit over. I apologize.
Dr. Lasello, thank you so much for the time and effort you put into preparing this presentation for us. We do have a couple of questions that we'd like to throw at you. I don't know if you saw the poll results, but approximately 70% of the respondents say they are not currently doing digital dentures.
Wow.
So I guess the first question would be, what is the best way to get started in digital dentures if you're not currently doing it?
Yeah, and again, that's why I went through that cherry picking session, and I truly think, if you're don't want to make any clinical changes, you do the wax rim bite. That is, there's zero change that you would do. That's a good starting point. And that'll get you into the digital design software. So what comes back to then is a resin try-in, and that'll be your first experience. That's a great, easy transition to start off with. I think you probably that seems to be the number one choice of transitioning. And don't make it one of your extraordinarily complicated cases. Get the garden variety case to start with, just to go there. Next would be the try-in trays. Patient has existing denture. You will gravitate to that because most of your patients present with existing denture, and that is the easiest way to be successful is to work off a patient's existing denture. Immediate dentures, maybe that's going to be your last transition, but I encourage you to look into that, work with the laboratory because you will provide patients better care. You'll help them immensely transitioning into removable dentures because the technology will allow you to do better dentistry. I can't get into great detail, but it just does. I'll turn it back.
Thank you so much for that answer. We have another question regarding any tips of what to capture when scanning for dentures. I know from the lab perspective, we have a lot of issues when they don't properly capture the landmarks for retention. So could you kind of speak to that a little bit?
Okay, now you're speaking, Matt, of doing an iOS scan
Yes.
clinically? Yeah.
Yes.
Again, that's kind of so they're scanning intraorally. Is that what you're referring to? Is intraoral scan or scanning
Yes.
denture?
Intraoral scan.
Yeah, as I said, intraoral scanning is it's a separate topic. And yes, there's good articles, good information that's out there, good YouTube things that you could kind of look at in different ways to scan. I find it to be a little bit on the difficult side. If I was a young clinician, I would master doing intraoral scanning of the maxillary arch because it's easy. That I could get successful quickly, and patients love the idea that you don't have to take an upper impression. Scanning the lower arch for me at this moment in time is a waste of my time. It takes me too long. I could do a preliminary impression in seconds as opposed to trying to control the tongue and try to hold the cheeks and it's actually an inconvenience to the patient to do the lower intraoral scan. Now that technology is improving because the manufacturers are coming up with better scanners, so that might change. But I think that's why I said the immediate dentures are a good starting point because you have so many markers with the with teeth in place. It makes it such an easier scan. Now, the other thing about doing the upper arch, you don't have to worry very much about the well, you do, but you don't. Your peripheral borders are not as critical because the upper denture retains more because of the intimacy of contact to the tissue, adhesion, cohesion, where the lower arch is stabilized by the physiology, which requires border molding. So doing a scan of the lower arch for me right now, it doesn't work. Others say you could do a scan of the lower, make a preliminary as a preliminary, then still get a tray back. But why waste my time? I could do it so much faster with an impression. So that's kind of my 2 cents on iOS. I'm certainly not the expert in that area, but that would be my goal as a starting clinician is to master the maxillary arch, which you can do pretty easily.
Right, thank you. Another question on you mentioned the monolithic. What, if any, limitations are there with the monolithic
Yeah, it's
material?
a good question. And there are limitations because there's mechanical limitations when uh, you may want a monolithic, but if your arches are large or they have a lot of undercuts, which requires them to be rotated into the disc as they're being or nested, we call it nested into the disc as they're being to be manufactured. You may not be able to do the monolithic. You may have to do the two piece, which is more forgiving because you're doing the base and the teeth separately, so you can kind of twist and turn them a little bit more freely into the disc. So there's some manufacturing limitations to the monolithic, and so each of these manufacturing processes has pros and cons. The laboratory could be your best guide. You may sometimes ask for the monolithic because you want the extra strength, but they may not be able to do it because of the arch uh, uh, morphology.
Great. And there's a follow-up question to that. What happens when a tooth fractures or chips on a monolithic setup? Can that be repaired or is it a redo?
It certainly could be repaired, but I think with this technology, well, first of all, tooth chipping, as far as a tooth falling out and whatever, that's gone. You don't see those kinds of repairs anymore. Even the chipping part, because it's a whole arch of teeth. It's not an individual tooth. So you're not going to see those typical denture repairs that you know, we see with the analog process. And if a significant fracture did occur, you redo the denture. It's not sometimes not worth to try to repair a denture. It might be actually easier to remake a denture, and that option exists because the electronic format is already locked in. So again, but it does repair. It's PMMA, it's polymethyl methacrylate. You can repair what can be repaired, and then you make a determination when you draw the line that the repair is more of a pain in the neck than remaking.
Great, thank you for that. I have another question from the doctor. He says, for lingualized occlusion, is the lab able to make a flat plane, and in parentheses it says 0 degree teeth on the lower arch?
No, not really. Yeah, I shouldn't say that. Yes, they are, but it's not worth the effort. But the lingualized occlusion, I would suggest you could ask the laboratory to equilibrate. Maybe there's a process in the design where you could equilibrate, and then you ask mark the teeth, and then you press a box and that adjusts the teeth, typically by like 0.1 millimeter of adjustment. You may want to ask the laboratory to adjust it, 3, maybe 4 times so that you get a little bit more equilibration. It doesn't flatten the teeth, but it makes the excursion a little bit, I guess, less cusp angle to the excursion. Now, the lingualized teeth do have a very modest cusp angle to begin with, but we don't have the 0 degree. And you can morph the teeth into the 0 degree. A lot of work on the laboratory side. And honestly, I don't think you'll be disappointed by equilibrating the process of the equilibration, do it several more times, get a little bit deeper of an equilibration, and I think that'll probably satisfy your goal of minimizing horizontal force to the denture.
And I guess as a follow-up to that question, can a digital articulation set the teeth in a true balanced occlusal setup?
All the teeth are preset. They're all preset, all pre-balanced to the best of the ability. And they're set up by some of the world's best technicians, literally. And they're finely equilibrated, so they're all preset into at least a stage of equilibration. Now, is it perfect? It can't be, because there's differences in mounting and arch forms and stuff like that. But by going through the equilibration process and actually adjusting, because it adjusts the teeth, it will account for differences of mounting and arch sizes and things. So it's about as good as it gets. And compared to, I was a prosthodontic program director, all my residents were trained. Day of insertion, we do a clinical remount, bring it back into the laboratory, and you equilibrate on the articulator to the final dentures. Then with this technique, I don't rarely have to do that, because the equilibration gets me where I want to be at the day of insertion without having to do a clinical remount. So it's a definitive technique. It works, and you can communicate to the laboratory if you want that equilibration done, and then how much you want them to take off, or how many times you want them to repeat the equilibration process. And again, as part of that communication that you work with the laboratory. But to answer that question, they are preset into a balanced occlusion.
Right, thank you. We'll do one more question, and really it's kind of a question of, if they aren't currently doing digital dentures and they want to get started, but they don't have a scanner, what's I guess the best way to get started?
Yeah, I'd say you work out something with your laboratory. And Ben, I'm sure at Arrowhead there's a convenience for a customer to ask for a patient to come in, maybe drop his dentures off to be scanned, or you can't obviously you can't do an intraoral scan, but you certainly could scan the existing dentures, and that might be the best way. You could get a copy denture, or as I said, the try and tray scan. But I would work out a something with your laboratory.
Yeah, I mean, most certainly we do use scanners here at the lab. We can do a whole host of scanning services for doctors who perhaps are just getting started and don't want to have that initial outlay for an intraoral
Understand,
scanner at the beginning.
understandable.
Yep. Great. Well, we thank you so much for your time and your expertise that you shared with us today. I think there's a lot of great information. And for those listening, we do at Arrowhead offer a removables course that is based predominantly on much of the information that Dr. Lasello has provided us. And so his expertise is at the heart of that course. So if you are interested in that, please reach out to us and we can get you signed up for the next available seat in that course. Again, we want to thank Dr. Lasello for the excellent presentation. We hope that all of our attendees found the information helpful. Please remember to fill out the survey after the webinar ends. Your feedback is crucial in planning future webinars. We will have another webinar in about 2 weeks, which will cover the topic of zirconia and how to select the right material for your cases. If you haven't already registered, you can go to our Facebook page and register for that event right now. Again, thank you for your time and attention, and we look forward to having you join us at future webinars. Until next time.
Thank you, everybody.